This episode of The Therapy Show is part of the Just Therapy podcast series, where we focus on values driven mental health topics rooted in family, faith, and tradition. Whether you're a therapist or someone seeking real, practical insights, you're in the right place. Let's dive in. Please note that the content provided in this podcast is for informational and educational purposes only and is not intended to replace professional mental health care, diagnose, or treatment. Always seek the advice of your own licensed mental health provider or medical professional regarding your specific situation. While I am a licensed marriage and family therapist and my guests are also professional counselors, the discussions in this podcast are meant to offer general insights and should not be taken as personalized therapeutic advice. Listening to this podcast does not establish a therapist-client relationship with me or any of my guests. If you are experiencing a mental health crisis or have thoughts of harming yourself or others, please contact a mental health professional, call 911, or go to the nearest emergency room immediately. You can also reach out to a crisis hotline such as the Suicide and Crisis Lifeline at 988 in the United States for immediate support. Every individual's journey is unique, and what works for one person may not be suitable for another, so please use discretion and seek appropriate care as needed. Well, hey, Melody, welcome to Just Therapy. It is so great to have you on the podcast this week.
Thank you.
So, can you share with our listeners a little bit about who you are, what you do, where you work, your specialties, all that good stuff?
So my name is Melody McKibben. I own a private practice called the Counseling Cove. We specialize in working with borderline personality disorder. We have a couple of different therapists, specialties with trauma, as well as substance abuse.
Okay.
And we are a Christian counseling group.
Mhm.
And so that's one of our big focuses as well. I'm actually licensed in 10 different states.
Man.
Now, I'm located in Texas, and we are completely virtual. As well as that, I am a certified personality disorder treatment provider. And I am actually currently in school for the doctoral of education program at Liberty
Oh, nice.
for community care units.
Well, you're a busy lady. Oh my gosh, you got a lot going
Yeah,
on.
lots.
12 states. That blows me away. So if you're listening and you're
Well,
looking
10
for
states.
10 states, sorry. So if
10
you're
states.
10 states, if you're listening and you're looking for a DBT certified therapist, I think Melody might fit that bill because you're all over the place.
Absolutely.
10 states, that's a lot. Okay. I know we're going to talk about the different level of care that exists when it comes to somebody who is in, I guess, crisis or needs acute help pretty quickly. This is a really interesting topic because I think a lot of people, like you were saying before we hit record, just don't understand what happens or don't understand the different levels of care, and it's very confusing. So, where would you like to start with that topic?
Yeah, so I wanted to talk about today a little bit about the different levels of care we have in the US. And then I wanted to have a big focus on what to expect in the inpatient level. And this is where somebody might be hospitalized for a short period of time if they're having an acute mental health crisis, if they are, say, actively suicidal, or if they're struggling with just not coping as well with life at the moment, just feeling like they just can't handle things at the moment, or they may be sent there by a therapist who feels like they are not safe, or they don't trust themselves to be safe for themselves or others, or if they may be a danger to themselves or others, or if they just feel like they need to be somewhere that they can feel safe, or they may be detoxing from a substance of some kind and they just need to be somewhere where they can be monitored 24/7 and get that professional help that they need.
Right. Okay. Great. So what would be the
So
first level?
So the first level is going to be kind of like a self-help
Mhm.
level. This is going to be the first non-professional level. And so these are things that all of us probably have done at some point in our lives. This is going to be maybe reading a self-help book, looking at different articles on the website, maybe looking at Psychology Today, reading articles, trying to just find ways to kind of help ourselves feel better. Maybe finding some coping skills or some mindfulness exercises online, those types of things.
Mhm.
And so that doesn't involve like getting counseling. That doesn't involve talking to a professional. It's just kind of a self help, and that works for some people, and sometimes that's all they need. That's good. That works for you. Then go for that.
Okay. Okay. Yeah, I am a self-proclaimed self-help junkie, personal development and growth junkie. That's like One of my favorite things when I go to the bookstore with my kids is, like, I just beeline for, like, the self-help. I'm like, "What is new in the world of personal growth and development?"
Hmm.
Yeah, what are we gonna find today? So I like that. That's awesome.
The next thing would be like a peer to peer
Mhm,
support. This is going to be something a little higher up, but it's going to still be peer led and not professional led necessarily.
mhm,
This would be something like an AA group
okay,
or like a grief support group, grief share, or something like that.
mhm,
It is facilitated by somebody typically, but they're not necessarily a professional, and they're mostly a peer group. And so this is a group. It's not group therapy, but it might be a group of just other people going through the same thing as you.
gotcha.
So
Yeah,
there might be a group for people who have, say, um, been going through divorce or like uh, NA or AA, are
gotcha.
examples of that.
Yeah, gotcha.
That- those are pretty popular
Mhm,
because it gives you a chance to be around people going through the same thing as you.
mhm,
So,
mhm. Okay. Yeah, and what comes to mind for me is I work primarily with the military population, so I think about the VA has a peer program, I believe. Well,
mhm.
depending on the VA, but they have peer programs there. I think that's pretty neat and
Yeah.
cool.
And then at your third level, you get into your first step in professional care, which is
Mhm.
going to be just your standard outpatient therapy. This is what you think of as therapy.
Are you tired of sitting in front of a computer to watch hours and hours and hours of recorded trainings so you can get your continuing education requirements fulfilled? Look, I was, and I decided to do something about it. I have created convenient on the go learning that's completely audio based. I call them pod courses. Well, what's a pod course? Think of it as a hybrid between a captivating podcast and a self study course tailored for you, my perpetually busy counselor friend. In my pod courses, you can explore subjects like addiction issues, ethics and values in counseling, holistic approaches, and much more, all while you're on the move. Whether you're commuting, jogging, relaxing at home, whatever, pod courses blend your favorite podcasts with enriching self study courses, perfect for those always on the go. How it works. So tune in anywhere, anytime. Enjoy the pod courses on any device wherever podcasts are available. Quiz yourself, solidify your understanding with a brief quiz after each pod course. Then, last but not least, certify your smarts. Achieve a score of at least 80% to receive a certificate of completion. If you're curious to learn more about my pod course offerings, head to the link lisamustard.com/pod courses or just click the link in the show notes. Pod courses are brought to you with pride by Mustard Consulting LLC, your trusted NBCC ASAP provider.
So we once every other week, it's just going to be typical day to day stuff that you're talking about or a specific issue that you're working on. Just working on coping skills, working through a specific concern or issue, doing different kinds of modalities or therapies. And this is a lot of people in the US and the world actually do this. And so it's a very popular thing right now, very common. And so that's often the first step into professional care. And a lot of times that's as far as anybody needs to go.
Mhm.
That's all we do at our facility, at our agency. That's all we do is just your standard outpatient care.
Gotcha.
That's as high as we go.
Mhm.
That's the typical, like I said, that's the typical therapy that you think of. And then sometimes, people will you may hear your therapist refer to something called a higher level of care. And this puts us up into the next level, which is going to be what we would call either a PHP program, actually stands for partial hospitalization program, or an IOP, which stands for intensive outpatient
Mhm.
program.
Mhm.
And under this, you're still getting that therapy, but you're getting it on a daily basis, generally 4 to 5 days a week, and typically for a longer period of time. So you may be at the facility, it may be outpatient at a hospital, but you may be going 5 days a week for like 5 or 6 hours at a time.
Right. Right.
And so you'll be getting that you'll be getting group therapy, you'll be getting individual therapy. A typical program would be like Monday through Friday, 9 to 4.
Right. Right. Okay.
And so that you're home on the evenings and weekends.
Yeah. Have you ever worked in a program like that?
I have not.
Okay.
I have not.
Yeah. Yeah. Um, I did. I worked in a addiction recovery program in IOP, and I was part of the evening program. It was so interesting, and I really enjoyed working in that setting. It was a lot of work, and it was very I felt like, we were getting new patients, like, every day. It was and everybody had different personalities, and everybody had different, experiences coming in. It was just a really interesting type of treatment to be a provider in, and I can only imagine the folks that came in for treatment, the success stories that come from it, and, of course, the ones that relapse or have to go through recovery a couple times, but they can be really great programs. They really can, if you find the right one
They
for you.
are.
Mhm.
Um, we have a good local one that's actually for adolescents in our area,
Mm.
and it's amazing.
Yeah.
So
Yeah, that's great.
uh,
Okay.
they do uh, use PHP and IOP interchangeably for terminology.
Mhm. Yeah. Yeah,
There's
I
not
think the
a lot of
PHP
difference.
well, I was just gonna say, I think the PHP, partial hospitalization, kinda throws people a little bit because they think, "Well, am I in the hospital? Am I like, what is that what does that look like?" So I like the IOP. I usually use those words more than PHP, but
Mhm.
it's the
Yeah,
same thing, really.
it is.
Yeah.
It is. Uh, I think technically when they first came out, when it first started becoming mainstream, partial hospitalization was that you would be in the hospital
Mhm.
during the week and then you would be home on the weekends.
Right. Okay.
I think is kind of what that distinction was,
Mhm.
but that's not really done anymore.
Right.
Now they're just kind of used interchangeably.
Yeah.
So,
Yeah. Makes sense. Okay. That's good history. I
so
didn't realize that. I know that.
yeah, yeah.
Okay.
So that's where the partial hospitalization comes from. Is you would be in for a set period of time, like 3 weeks or 2 weeks, and then you'd be home on weekends. So
Mm.
that's where the partial hospitalization came. I think, but they found that the IOP model worked just as well.
Mhm.
And there was actually more compliance with treatment because of that. So,
Yeah. Makes sense. I
so
can see that.
yeah. So then the next level of care is going to be inpatient. And that's what we're going to talk about today.
Mhm.
Uh, and inpatient is going to be uh, as needed for what we would call acute crisis stabilization. And so this is going to be when somebody is just not safe to be outside of 24/7 care.
Mm.
So they may be had active suicidal thoughts, or they may have had a suicide attempt. They may be having active delusions and hallucinations that are telling them to harm themselves or harm someone else. They may be going through severe withdrawal symptoms from detox that are causing psychosis or psychotic symptoms. And they just need to be somewhere in an environment where they can be monitored 24/7 so that they know that they're safe and so that others are safe as well. And so they can be monitored for effects and they can have, a lot of times it's a medication issue where they need, uh, maybe a medication is just not working as well as it should, and they need to be monitored for that, go through a medication change. So they are in the hospital. So they do sleep there, eat there, live there for a short period of time, typically 7 to 10 days, sometimes longer, sometimes shorter.
Mhm.
Uh, and so they have individual therapy there on a daily basis. They do have group, they have different types of activities, art therapy, recreation therapy. They do have medication management there. They meet with a doctor, a psychiatrist on a daily basis. They also meet their medical needs. So if they have any medical needs, they meet with an actual doctor, like an MD or a nurse practitioner as well. So, and they're under 24/7 monitoring.
Okay. Yeah. So when you think about inpatient, it's after they are done with the inpatient, what I mean, I know what happens next, but, like, can you share with our listeners, like, what happens once they kind of are done with the 7 to 10 days and they're not maybe a risk to themselves or others, or their medication's been figured out, or, whatever the issue is that brought them in is, uh, what's the word I'm looking for? Like, they're stabilized. What happens next usually from there?
So it really depends on what their needs are.
Mhm,
A lot of the time, they can sit down into like an IOP program, uh, or if they're still needing something more longer term,
mhm,
sometimes they will have the option to go to like a residential placement. You do often see this if the issue was substance abuse withdrawal or something like that. They may go into more of a residential treatment. And this is more of a longer term, like a 1 to 2 year rehabilitation, live on site type of thing in another community. And we just, those referrals are made when they're needed.
mhm.
And so they'll step down, there'll be some type of step up. It
Okay.
may be that they get directly with their therapist within 3 days of discharge. And there are discharge requirements that we do want to see that they are set up with a therapist, with a psychiatrist. There has to be some kind of discharge plan in place. And that usually starts getting worked out upon admission. They start working on discharge planning. So trying to
Yeah,
get some of those supports in place.
yeah. So I guess depending on what is discovered in the inpatient setting, the next level of care will be determined. So it could be that they go to a recovery, addiction treatment facility
Mhm.
where you said 1 to 2 years. Did you mean 1 to 2 years or 1 to 2 months?
So it can vary.
Okay.
Uh, some of the programs are longer. Some of them are 18 months
Okay.
or
Okay.
more. Some of them are as short as 6 months or 3 months. It just depends on the program.
Mhm.
Uh, a lot of the residential ones, uh, there's like, there's some in Florida, there's some in Colorado, there's Padre Allen. Uh, some of them are 18 months, some of them are 6 months. I think most are going to be around 6 months.
Mhm.
Only.
Yeah. Okay. So
So,
there's that option, and then let's say it's not an addiction issue, it's more of a, traumatic or trauma experience that maybe has led to while they're inpatient, maybe they get a tentative diagnosis of borderline personality disorder or major depression or things that are outside of addiction, and I'm not saying that those things can't coexist with addiction because we know they do, and
yeah.
they would be admitted and that would be handled in the, addiction recovery program or treatment program. But what are other things that usually come out of somebody who goes inpatient? Like, what is that I guess, what are the diagnoses that might be tentatively given to them until they get more into therapy?
So, some pretty common diagnoses upon discharge are major depressive disorder. Uh,
Mhm,
Bipolar is usually provisional because you don't really have enough time in the hospital to really do a thorough evaluation on that.
mhm,
Borderline is another one that you really can't do a thorough diagnosis on that. You really have to get to know the client over the course of months,
mhm,
sometimes a year or more to get to know the client. But they can do a provisional or a rule out. But a lot of the time, they just put on like a major depressive disorder or a generalized anxiety disorder on discharge
mm,
just to have that on there. And then they may have a couple of rule outs for things like bipolar or uh, BPD or schizophrenia,
mhm, mhm. I
more severe things like that that
Yeah,
need further assessment.
yeah. So pretty much any diagnosis is gonna be provisional because like you said, you need to get to know the the patient, need to get to know their history. I mean, you do a deep dive as
Right.
their therapist or their next level of care as to
Right.
but things like anxiety and depression, those are gonna be the first presenting symptoms that any of those provisional diagnoses, like, you gotta rule out, are going to show up. I can totally see how if you're listening and you're unsure, like, your friend or your family member has, these symptoms of depression and anxiety, you don't really know what the root cause is until they get into more of this, like, IOP setting or one-on-one therapist setting where there's more time, whereas, like, inpatient's gonna be, like, stabilization and make sure that they're not a threat to
Right.
themselves or others. Okay, got it.
Right.
So
So,
most of the
yeah,
so 99% of the time, you definitely need to follow that discharge plan because I see
absolutely.
so many people who do not wanna follow the discharge
Absolutely.
plan, and
Yes.
that's
Follow the discharge plan.
part of the problem to begin with
Mhm.
usually. So, okay, makes a lot of sense.
The
Mhm,
doctor and the inpatient is taking a guess,
mhm.
and they're going to either start you on a medication or change your medication. But it is a guess, it is a trial and error. Um, there is actually, you can request, and some hospitals do it, some don't. There's something called a GeneSight test, which is, I don't know, are you familiar with it at all?
No, mm-mm.
It's actually a blood test that you can request, and it will look at your blood chemistry and will give a list of what meds would work better or best for your body chemistry,
Okay,
a list of the site meds. And so that can be really helpful in helping, narrow down what meds might have a better chance of working.
okay.
And so that's a really cool technology that they have. Um,
Yeah,
and sometimes that can be requested in inpatient. So, if you yourself are inpatient or if you have a loved one in inpatient or a child, you can request that and see if that's something they offer. That way they're not just because right now, kind of the model with inpatient is we're just gonna throw a med at it and see what sticks and what works and what doesn't.
right,
And so that's, unfortunately that's how we have to do it sometimes because we just don't.
right,
Uh,
right. Right, and just because the med that you are prescribed isn't working out for you doesn't mean that there's not another one that could work for you.
Right,
So you don't wanna,
right,
like, totally give up and say, "Oh, it's not working." Definitely talk
right.
with your doctor and, see what other options and then I have heard this too, like, if one of your family members is taking a medication and it works well for them, then chances are it might also work okay for you too. I guess that's that whole genetic thing that you
Yeah,
you mentioned, so
yeah.
okay. Yeah, alright. So what do you is that all the levels? Did we cover? Did you cover all the levels?
So,
Okay.
yeah,
Okay. I thought
um,
so. Okay. So in terms of like families and what they can expect if somebody goes inpatient, can you maybe give an overview of because I know there's a lot of unknowns for families when they
there
say
is,
Mhm.
there is, you see TV shows us a lot of things, and it's great for comedic value. We have people throwing water coolers through the window. Um, you have you ever seen the movie One Flew Over the Cuckoo's
Yeah.
Nest?
Oh, yeah.
Um, Jack Nicholson tosses that
Yeah.
water cooler through the window.
Right.
We have, depictions in cartoons.
Mhm.
The Simpsons had an interesting episode in the 90s of Homer being put in a psych hospital, and he was in the straitjacket and
Oh,
sitting in the
wow.
corner rocking back and forth, and just some of the stereotypical, Patch Adams is another one,
Oh,
the
and what
disorderly orderly.
and, Girl Interrupted? Did you see that?
Mhm.
Yeah.
Yeah, yeah,
Mhm.
that one is a good one. But there are, so many depictions of what people think is a mental health inpatient facility on media and TV.
Mhm.
And, all of course, all depictions have some element of truth in everything you see. They come from somewhere,
Right.
but it's not like that. We're not drugging patients so that they're asleep in their bed for 24 hours and in restraints and all of that. And so it's not like that. Back in the Middle Ages, okay, we had more of an asylum approach, and that might be more of the norm back then. But mental health care has come a very, very long way in the last few decades. And so we've learned a lot, and we've learned that it's more about, how can we give this person the treatment and help they need so that they can function.
Yeah.
Yeah. And that's not going to be by keeping them sedated and drugged. And so 30s, 40s, 50s, you saw a lot of that, just keeping them drugged, keeping them down. The whole stereotypical, somebody's acting really crazy and then they give them a shot and it's
Yeah.
just like, they just pass out.
Right.
We do have medications that they use that can calm somebody down that is actively hurting or posing a danger to themselves or someone else like that. Um, but they're very time limited and they only last for a few hours. And so, in fact, some states have laws about the length of time that you can actually let somebody be sedated. And so, uh, some of those laws are no more than 6 hours or,
Mm.
no more than 12 hours or something like that. So, and even the medications they use now, some have been not allowed anymore. So, like Thorazine was a big one that was used.
Yeah.
And then Haldol was a big one that used to be used that's not really used anymore, you know?
Yeah. Okay.
But just wanted to kind of what to expect in the process. So, some realities of what to expect. First of all, there's an admissions process. Well, a person can be admitted to the hospital in several different ways. One way is their therapist, care, and I don't want to scare people into not telling their therapist something because, be honest with your therapist, please. But if the therapist determines that somebody is an imminent threat to themselves or someone else, they will. I mean, we do have an obligation as mental health professionals. We do have an obligation to put the client first and make sure that their safety is paramount to us. So we will, if we have to, absolutely as a last resort, make that referral to inpatient care. Uh, So that's one way that people enter inpatient is through a therapist referral. We can make that call and get them admitted. Uh, they can get admitted through an ER. This comes sometimes if, go to any emergency room and if you're feeling suicidal or if you're feeling like harming yourself.
We'll get back to the episode in just a sec, but I wanted to talk to you about something important. Have you ever felt like you're ready to redefine your relationship with alcohol, but don't know where to start? What if I told you there's an app that makes it simple, supportive, and even enjoyable? Introducing Reframe, the mindful drinking app that's helping thousands of people take control of their habits one day at a time. Whether you're looking to cut back, quit, or just build healthier routines, Reframe is packed with tools, expert guidance, and an uplifting community to help you succeed. Reframe has received outstanding reviews, with users praising its user friendly interface and effective features. In fact, 91% of users reported significant reductions in alcohol use within just 3 months. So take charge, feel better, and let Reframe guide you to a healthier, happier you. Take the first step towards mindful drinking with Reframe because a healthier you is within reach. To learn more about Reframe and try it for free for 7 days, just click the link in the show notes or go to lisamustard.com/reframe.
They can start that admission process for you. I will say that expect a very long wait. That's the first thing to know is it's a long process from wanting to be admitted to actually be.
Mhm.
It's not unheard of for it to be 5, 6, 7, 8, 10, 12 hours, especially if you are going through the ER. And the reason this is they have to clear you medically first. So they have to do blood work, urine screen, and they have to clear you medically because it's the inpatient hospital. They can't take you if you're not medically safe. So that's the one thing. Just patience with the process.
Mhm. Okay, so that's good to know. If you come in and you have a heart condition, they're not going to put you in inpatient because they're not set up
Right.
to care for somebody. So that makes sense. Makes totally
Correct.
sense. Yeah. So that's what
Yeah.
they're doing. That's why that's really it takes so long. Okay.
Yeah. So if you just came in and you had just, for example, taking a bunch of pills.
Mm,
They're going to put you in, you're going to be in the regular hospital until you're stabilized. And so then that's going to take a while. And then they'll start working on getting you a bed.
gotcha. Okay.
So they have to clear you medically first.
Okay.
Uh, There are some hospitals that will allow a direct admission,
Mhm,
and that's just knowing the hospital in your area.
mhm.
We have one in our area that it's for adolescents, and it will allow a direct admission where you can call and say you need to bring somebody in. It can be a parent, it can be a therapist, it can be whoever. And as long as they're medically stable, you can just bring them straight in for an evaluation. Intervention. But that's not the norm. I wouldn't say that's the norm. Normally, you're going to have to go through some sort of other professional to get it.
So I wanted to ask the question like, if you have a child or an adult, a teen, and you go to the pediatrician, can the pediatrician make that referral
Yes.
for the parent? So you can
Yes.
kind of bypass the ER if you have to.
Yes.
Go to
Yes.
like, so maybe, okay, so that's good to know. Yeah. Okay.
So any medical professional, any mental health professional
Hmm.
can make that call, can make that referral.
Okay.
The doctor, pediatrician could definitely make that referral. Uh,
Gotcha. Okay.
so that would be the case of maybe the teenager is um, making a suicidal outcry in the doctor's office. Talk to the parents and recommend, hey, I think that they probably need to be evaluated for inpatient.
Hmm.
And that's another thing to mention as well is you're going to be evaluated for inpatient. It doesn't necessarily mean you're going to go inpatient. And so what I mean by that is inpatient is kind of a last resort to keep you immediately safe. And so just because you're being evaluated for inpatient doesn't necessarily mean you're going to meet the criteria for inpatient. And you have to be you have to be an immediate threat to yourself or someone else uh, to meet that criteria. So they may give you that inpatient evaluation and decide that you don't meet the criteria, and then they may make a referral to like an IOP or a PHP program.
Gotcha.
Sometimes people just need that little bit of time to just calm down and,
Hmm.
get things kind of just straight in their mind. And they're just in that moment is they're feeling that way, but they're not actually feeling they want to hurt themselves.
Right.
And so
Yeah.
it's just the heat of the moment thing.
Right. Okay. So when somebody does go inpatient, then what can the families expect? I mean,
So
I'm just thinking
there
about the
is,
movies.
yeah. So movies, well, in the movies, you're going to see them, they're gonna be taken away, dragging, kicking and screaming, and,
Right.
there's
Right.
that song, "They're Coming to Take Me Away."
Yeah. Yeah. Yeah.
That song,
Yeah.
yes. Um, in real life, they are going to be given an intake in a Rio, and this is gonna be, probably generally a nurse
Mhm.
will be explaining the whole process. They're gonna go over the rules of the facility. They're gonna go over what belongings you can and can't have, and there's a whole list of contraband that you cannot have.
Mhm.
Uh, and we'll go over that a little bit. They are going to do a physical exam. And so I do tell clients to kind of be prepared for this. They will typically want to look at every part of your body. So they will have you get down into a gown, like a hospital gown, and they will put men with men and women with women.
Mhm.
And the purpose is they want to see every scar, everything on your body so they can make document of it.
Mhm.
And so we're not talking like a strip search like in prison, but it's going to be very uncomfortably invasive.
I
So
gotcha. Okay.
it's definitely something to expect.
Okay.
Uh,
It's good to know.
and they are going to wash your clothes when you get there, no matter what.
Mhm.
So be prepared that you're not going to keep your same clothes on until they're washed.
Mhm.
Uh, just because cutting down on infections and potential bed bugs and germs and all of that, it's going to be non-negotiable. They're going to wash your clothes and put you in a gown. So that's something to just expect ahead of time, just to know that, hey, this is gonna be a thing.
Mhm.
So that, there's going to be some anxiety, going to be a very stressful time, but it really is for your own benefit.
Mhm.
And that's something that I think catches people off guard a lot is that.
Mhm.
So,
Okay.
and
That's
then
good to
they're
know.
going to go over what meds you're on. They're going to go over your background, your mental health history, your medical history, and then they will do your vitals. They'll do a quick workup and they'll, you know, do all that. You'll be able to bring belongings with you. There are very specific requirements about what you can and can't have, obviously for safety reasons. So we're talking about that. You can't have, they don't allow any personal electronics. So they're going to take your cell phone away.
Mm.
And I know that that's really hard for people because I know I love my cell phone. And that would be a big factor is I don't want my cell phone taken away.
Okay.
So you can't have any clothing with strings or zippers.
Mm.
You can't have any hoodies. Nothing goes over your head.
Mm.
No, like I said, no strings and no zippers is the big one. Nothing with sharp objects. So you can't have shoelaces. And some places have other rules too. They will give you a list of things that you can't eat. So
Yeah.
you're not allowed any outside food or drink. But that's that's just for allergen reasons and safety
Sure.
reasons.
What about communication with your family or
Yeah. So communication with your family is going to be encouraged. That's going to be something that they will give you a schedule. So you're going to have a schedule of communication with your family. Typically, there's going to be a communication schedule. So it's different when you're talking adolescent versus adult. So with adolescent, that communication schedule is going to be a little more restricted simply because they are wanting to get more involved in group activities and more structured, because typically they're also doing schoolwork as well.
Mhm.
And so they're that way they don't get behind in school.
Mhm.
So typically there's going to be phone call time and there's going to be set visitation times. Visitation times in person are usually once or twice a week in the evenings or weekends. And then phone call times are every day and at certain times.
Mhm.
You won't have phone call times during planned activities. They'll have the phone shut off
Mhm.
and you won't be able to have visitors outside of visitation times. There are exceptions. You can have a pastor visit anytime and a lawyer is just like exception to that. So
Okay.
pastors and lawyers can always come visit whenever.
Okay. And then what about if the release of information being disclosed to parents if it's an adolescent? How does that typically play out?
So every patient is given a code number. It's usually 4 digits.
Mhm.
It's usually the last 4 digits of their patient ID.
Mhm.
And anybody who calls or visits has to have that number.
Okay.
So with adolescents, it is only given to the parents,
Mhm.
nobody else. And depending on the facility, uh, that's the only person the child can call is the parents. So with adults, the patient is free to give it to whoever they want. But anybody who calls is going to have that ID to talk to them. Otherwise, we can't say whether you are or not a patient at the facility.
Right. Okay, so that's how
So,
you communicate. That's the release
mhm,
of information, like, it's like a code, because you don't
yes,
want like, let's say it's a kid and they're, best friend, but they don't want their best friend to
right,
know. So the best friend's trying to
right,
find them and they just call. Okay, that makes sense. Yeah.
yeah.
Okay.
And so that also works if the nurse calls to give any updates.
Mhm.
Which, if it's an adolescent, they will call you and give daily updates,
Mhm.
and they will ask you for that code to make sure that they are talking to you. So
Okay.
that's just to keep things secure, HIPAA compliant,
Sure.
and uh, you can add people to that release of information if you wish as the parent.
Mhm.
So uh, both parents actually have to be explicitly listed.
Mhm.
So
Okay.
even if you're married, it's not just implied for both. They both have to exist. So,
Okay. Okay.
which is interesting.
Yeah, that is interesting because you could be living
Yeah.
in the same house and they don't wanna talk to dad or they don't wanna talk to mom, but that's gotta be
Yeah.
hard. That's gotta be really hard for
Yeah.
everybody involved, It's just a lot.
Yeah. Yeah. I mean, but I could also see, it might be an abuse situation or
Sure.
something like that.
Yeah, absolutely.
Could be at play. So I can understand the reasoning for it.
Hmm.
Families can expect, especially with adolescent, they're going to want to have a family planning meeting. They're going to want to have a family meeting before discharge. And it's a group family therapy session to just kind of see okay, what led us here? What can we do different? And they're going to want to put a safety plan in place. And the safety plan is basically kind of how do you know how do you know when you're starting to feel bad? Uh, what kind of resources do you have? Who can you talk to? Where can you go?
Hmm.
What are your reasons for living? And this way that the patient has this when they discharge, they have this go-to safety plan so that when they start having these thoughts again,
Hmm.
or they start having these feelings, they're able to utilize them.
And so the parents are brought in on that, and so they can work on
Yes.
it together. Okay. Yeah.
Yes.
If you're not an adolescent and you are in there as an adult, it's a similar thing, I'm guessing, but it's not unless you want to bring
Right.
somebody in. Okay.
Right. Right. They did discharge with the safety plan,
Hmm.
uh, which is a very good thing. So it gives the patient something that they can look at, but it also covers us therapists for liability
Hmm.
reasons.
Sure.
So
Yeah. Okay. Well, this has been really helpful. I mean, I learned a lot about what happens, things I didn't know. Being a therapist, I don't know these things. And a lot of the times when you're, I guess, depending on the relationship, if you have a patient that goes inpatient and they come back to you, you're probably going to want to have a debrief as to what it was like and
mhm,
all of those things as a therapist. But if it's a new patient to you, you're still going to want to know
yeah.
all the ins and outs of what it was like. Okay, so is there anything else you wanna share about the different levels of care?
No, with my population I work with, I do get a lot of clients who do go inpatient and then come back, and
Mhm.
so it's a pretty common thread. Um, it's not always the most pleasant place to be. People don't really like being there, even though a lot has changed in the
Yeah,
last few decades. It's still not. Nobody really wants to be there,
yeah.
but it's not necessarily meant to be pleasant. It's meant to keep you safe until you're stabilized. So,
Right, and that's why it's a short amount of time. So,
right,
it's as short as
right,
possible until they feel that you are safe.
right, right,
Yeah. Okay, and then depending on the discharge plan, it could be back to your therapist or IOP or PHP or lots of
right.
different things. This has been really helpful. So, once again, tell everybody how they can find you if they are curious to learn more or
So you can reach out to us at www.counselingco.com.
okay.
And I'm sure, Lisa, you'll have the
Oh, yeah,
website
I'll put
listed.
everything. Do you guys have, social media or newsletter or anything
Yes,
that
we
you offer
do.
there? Okay.
We have Instagram, we have Facebook.
Okay. Alright.
Instagram is Counseling Cove PLLC.
Mhm.
Facebook, same thing.
Okay. Well, I'll put direct links in the show notes so you
Okay,
guys don't have to
great.
remember that. Just go to the show notes. And Melody, once again, is licensed in 10 states. That blows me away that you have so many different licenses. So I imagine that you're helping so many people. And thanks so much for coming on the podcast. It's just been awesome.
Great.
Thanks.
And I'll give you my states so you can list them in the notes as well.
Awesome. Okay. Well, thanks for being here.
All right. Well, thank you for having me.
You're welcome. Please note that the therapy show with Lisa Mustard is for informational and entertainment purposes only and not a substitute for professional medical or mental health advice. Always consult with your therapist, doctor, or physician before implementing any suggestions from the show. The Therapy Show with Lisa Mustard is edited and engineered by Chelsea Weaver. If you're looking to start a podcast or ready to take the editing off of your plate, be sure to visit chelseaweaverpodcasting.com. Well, that wraps up another episode of The Therapy Show with Lisa Mustard. I know there are hundreds of thousands of podcasts out there, and I'm thankful you've chosen to listen to mine. Be sure to visit lisamustard.com to access the show notes and discover all the pod courses and other continuing education offerings. And I'd be grateful if you subscribe to the show. Thank you.